So we will discuss under these headings: first introduction, then classification of renal tumor, clinical feature, diagnosis and treatment. So first is the introduction. So renal tumor account 2 to 3% of all adult malignancy. This is the most common lethal urological malignancy, bladder, prostate, and upper tract urothelial carcinoma. So renal tumor is most lethal. So this is another MC. Most lethal urological malignancy is the renal tumor. Incidence is the 16 new case in 1 lakh population per year. Most common age of presentation be above 55 years. But can seen in earlier age of presentation. If tumor in earlier age, then tumor will be more aggressive for usually more or sarcoma type tumor. Or if in earlier age presentation, tumor will be more familial, genetic. So two term sporadic term or other is the familial. So most of the tumor are sporadic and 4 to 6% are bilateral. The renal tumor RCC are rare in the children. Children's renal tumor are Wilms tumor, and these account around 7 to 10% of all pediatric malignancy. So you can keep in mind that this is the most lethal urological malignancy, and most are sporadic. 4 to 6% are bilateral. So etiology, these are etiology: smoking, obesity, hypertension, patient on prolonged diuretic, and occupational exposure to petrochemical and dye, and acquired renal cystic disease. Acquired renal cystic disease seen in the patient with long-term hemodialysis. Patient usually on 5 to 10 year on hemodialysis. These patients develop multiple cysts in the kidney, and these cysts will progress to renal tumor. So classification of renal tumor is the benign or malignant. Benign tumor is the renal cyst, adenoma, oncocytoma, AML, and cystic nephroma. And malignant tumor are clear cell carcinoma, papillary RCC, chromophobe RCC, collecting duct carcinoma, medullary tumor, and familial RCC and sarcoma. So most common benign renal cyst is the benign renal tumor is the renal cyst. And if suppose they are asking the most common benign enhancing renal tumor, then answer will be oncocytoma. So if they directly they will ask the most common renal benign tumor, then is the answer is the renal cyst. If answer is they are asking most common benign enhancing renal mass is oncocytoma. Other most common malignant tumor is the clear cell RCC. So please concentrate. I will ask all previous slide. Okay. So now first is the oncocytoma. Oncocytoma is benign epithelial tumor arising from collecting duct, and it accounts 5% of renal tumor. Etiology is unknown. Most tumor found incidentally and usually seen after 7 decades of age. More common in male, and this is the most common benign enhancing renal mass. I already told you. So okay, keep the oncocytoma arise from the collecting duct. So this is a benign unifocal tumor, and average size around 5 to 8 centimeters. So is usual at presentation also tumor is the very big size. So can coexist with RCC in 10% of case. On cross-sectional imaging, presence of central stellate scar. So this central stellate also seen in the cross-section also on CT scan also. So this is the MCQ: central stellate scar seen in the oncocytoma. And angiography, spoke wheel appearance. So this is another MCQ: the spoke wheel appearance seen in the oncocytoma, and central stellate scar seen in the oncocytoma. So central stellate scar also seen in the cross-sectional imaging on CT scan and also on cross-section on gross specimen. So grossly tumor can confuse with the chromophobe RBC. So on diagnosis there is a confusion between this is the oncocytoma or chromophobe RCC. So this is differentiated by the IHC marker. So RCC is then positive for CK7, cytokeratin 7. and this tumor is well encapsulated and tumor is variable size. On cross section, homogeneous and characteristic magni brown in color. So also magni brown color tumor is the oncocytoma. On histology, the tumor is cytoplasm is strongly eosinophilic, uniform cell and uniform cell with numerous large mitochondria. So these are known as megalomitochondria. So megalomitochondria seen in the oncocytoma. The differential diagnosis is chromophobe RCC. The oncocytoma negative for CK7 and negative for colloidal iron staining, and the oncocytoma positive for CD117. So treatment is the partial nephrectomy. Why is the partial preferred? Because it is a benign tumor. So benign tumor usually prefer approach is the partial nephrectomy. So keep remember there is the colloidal iron staining for renal cell tumor, and CK7 positive for chromophobe RCC, CD117 positive for oncocytoma. These are all are your love and belly, that this all matter, theory matter. Please come. So actually this love belly topic is written by Dr. Nitin Kekre. He is the HOD from CMC Vellore. So he also my guide. He was my guide during my tenure. So this is the very important topic. Okay. So this another benign tumor is angiomyolipoma. Angio means blood vessel, myo any smooth muscle, and lipoma and fat content. So this is unusual tumor of kidney, not usually associated with the tuberous sclerosis. And histologically they are composed of fat cell, dysmorphic blood cell, and sheet of smooth muscle cell. And this is benign tumor usually detected incidentally. And AML is more common in the female than male. So these are also MCQ more common. This renal tumor more common in the female. And tumor associated with tuberous sclerosis is AML. So because it angiomyolipoma, the tumor has blood vessel, so there is a chance of intratumoral bleeding. So kidney is a retroperitoneal organ, so there is a chance of bleeding to retroperitoneum. This is known as Munderlich syndrome. So when there is a retroperitoneal bleed, patient usually present with a sudden onset flank pain and hypotension, and sometimes patient in severe shock. And the pregnancy is the risk factor for the retroperitoneal bleeding from this tumor. So if suppose this tumor, usually I will tell you the treatment according to size of the tumor, but in the pregnancy, even small tumor, there is a chance of bleeding. So we will go earlier for surgical approach. So on USG, the AML show bright echogenic mass with high fat content. CT show intralesional fat density with -15 to -20 Housefield unit. So you know this is the Housefield unit of fat is in minus, negative. Okay, so because of fat content, the Housefield unit is -15 to -20. If suppose renal tumor, that these are enhancing tumor, so they are at least more than 15 Housefield unit. If suppose non-contrast CT, first we are doing non-contrast CT. Non-contrast CT, what is the Housefield unit? After contrast enhancement, how much enhancing tumor? If suppose more than 20 or more than 15 Housefield enhancement, that is a highly suggestive of renal malignancy unless proven by biopsy. So management of AML depend on the size of tumor, risk of bleeding, and symptoms. If asymptomatic lesion is smaller than 4 cm, should we follow with yearly ultrasound? So if less than 4 cm, patient is asymptomatic, then we can yearly follow up with the ultrasound to monitor the size of the tumor and growth of the tumor. And nephron sparing surgery such as partial nephrectomy is preferred option because this is a benign condition. And another approach is the angioembolization. So if suppose patient presented with a severe shock, hemorrhage, and patient already known case of CKD, and patient is the multiple comorbidities, the patient is unfit for surgery. such patients prefer for angioembolization. Another drug is the mTOR inhibitor, is the everolimus or sirolimus, especially in syndromic patient associated with the tuberous sclerosis. So other is the familial RCC. Familial RCC are VHL syndrome, hereditary papillary renal cell syndrome, Birt-Hogg-Dubé syndrome, Cowden syndrome, tuberous sclerosis complex, and SDH. So what is Cowden syndrome? So any gene mutation in Cowden syndrome. So this is the autosomal dominant disorder and is the P10 gene mutation. So it will involve hematoma. Hematoma is the large intestine, RCC, and endometrial tumor, and thyroid malignancy. Which thyroid malignancy is more common? Follicular cell carcinoma. Okay, so follicular carcinoma is the more common. So VHL disease. So this is the VHL. This slide is very important to keep in mind. If you remember, you will in medicine also you will read that VHL syndrome, and in surgical part also in your exam. The examiner, when the examiner makes the medicine paper, that he can make the multiple MCQ from this part, and if surgeon paper making the question paper, then it will come from the surgical part also. So keep in mind that every point is the MCQ. So it is the autosomal dominant. First is the second is the it is deletion of the short arm of chromosome 3. So sometimes they will pick 3q, 3p. Okay. So keep in mind deletion of short arm of 3p. And which type of malignancy is more common is clear cell RCC. And this malignancy, what is the difference? These all familial tumor are multifocal. Multifocal in suppose upper pole, mid pole, and lower pole. So sporadic tumor are either they are one location, either unifocal, either at upper pole, lower pole, or mid pole. But in these are familial old syndrome, they are multifocal and usually bilateral. And earlier age of presentation, usually in under 30 years of the age. So young patient with renal tumor and especially bilateral, then go for genetic analysis. So this syndrome, this disease constitute retinal angioma, in CNS cerebellar hemangioblastoma, in adrenal gland pheochromocytoma, and endolymphatic sac tumor in testis, and pancreatic and renal cyst, and epididymal cyst adenoma. So all things you have to memorize this thing. Other is the tuberous sclerosis complex. This also is the autosomal dominant disorder and involves the TCS gene on chromosome 9q and 16p. So this syndrome has triad. Triad is the seizures, adenoma sebaceum, and mental retardation. SAM, you can remember by SAM, seizure, adenoma sebaceum, and mental retardation. And in this syndrome, most common renal tumor is the AML, angiomyolipoma, 40 to 80% case. Other renal tumor are renal cyst and RCC only 2%. And other cardiac subependymal giant cell astrocytoma also seen in the tuberous sclerosis. So all are MCQ, which is the component of tuberous sclerosis. So remember by that skin lesion, adenoma sebaceum, seizures, mental retardation, renal RCC, renal cyst, and AML. So these are the type of renal cell carcinoma. Clear cell papillary, most common is the clear cell RCC. In how many percentage? 70 to 80%. And genetic factor is loss of deletion of short arm of chromosome 3, and usually associated with VHL syndrome. And the rarest tumor are collecting duct carcinoma and renal medullary carcinoma. So renal medullary carcinoma usually seen in the patient with sickle cell anemia. So keep even remember, patient with sickle cell anemia, answer will be renal medullary cell carcinoma. So a clear cell carcinoma is usually sporadic, and associated with the VHL syndrome. And clear cell RCC is the worst prognosis, poor prognosis. Among them is the clear cell RCC, and best prognosis is the chromophobe RCC. Good prognosis, okay. So this is also very poor prognostic histological type is the clear cell RCC, and the best prognosis is the chromophobe RCC. And collecting duct carcinoma, also known as Bellini duct carcinoma, and this one also has the aggressive tumor arising from the renal medulla. So this is the centrally located tumor, because renal medulla, this rest of the tumor are the cortical location. So this tumor is the medullary location. So centrally, the mass in the central part of the kidney is the collecting duct carcinoma. So keep remember, this is most common and worst prognosis, and the chromophobe is the best prognosis. So this is the picture showing that upper cell, the mass in the upper pole of the kidney, and the dense yellow color is the fat content in the gross specimen. So this is taken by CMC only, this gross specimen. So clinical feature, the majority of patients are asymptomatic, and they are incidentally detected. Incidentally detected means patient on usually screening, patient went for usually screening of abdomen, and on ultrasound detected some renal mass. So this is the such tumor we are telling incidentally detected. So patient present with a dull aching flank pain. Why dull aching flank pain? Because tumor arising from cortex, and because of tumor slowly growing in size and stretch the renal capsule. So because of stretching of renal capsule, patient has dull aching flank pain. Hematuria. Why hematuria? Why hematuria in the renal tumor? Hematuria usually late sign and usually in the advanced stage of the tumor, because the renal tumor are in the cortical part, and when tumor invade to pelvic calyceal system, then hematuria will start. Other is the palpable abdominal mass. Other constitutional symptoms are fever, malaise, weight loss, and anorexia. These are advanced features that seen in patient with metastatic renal cell carcinoma, advanced disease. So triad of renal tumor is the flank pain, gross hematuria, palpable abdominal mass. So this triad rarely seen nowadays, because that easily availability of ultrasound. So small tumor in earlier stage we are detecting the tumor. So this triad seen only 10% of cases. This one also MCQ, that this renal triad of flank pain, gross hematuria, palpable mass seen in the only 10% of the population of renal tumor. Advanced disease, patient can present with the bilateral lower limb edema. So any renal tumor patient and has bilateral lower limb edema, then what you will think? Because renal tumor is the also that tumor usually carcinoma by lymphatic spread, but with the renal cell carcinoma, lymphatic plus hematogenous spread. So the venous, the tumor thrombus pass through the renal vein and goes to the IVC and obstruct the IVC. Because of IVC obstruction, patient will present with the bilateral lower limb edema. Other thing is the right sided varicocele. Varicocele is more common on which side? Left side. Why left side? Answer is true, that is more common on left side, because left side is that so more common on left side, because that the length of the, because left side, left testicular vein drain in the left renal vein, and right testicular vein drain in the IVC. Okay, anatomy you already read na in first year. So left side reach in the renal vein and right side IVC. So long course of this thing. Other thing, because of the sigmoid colon compressing the renal vein. So that's why more common on the left side. or right side if varicocele is there, then something happening in the IVC, because when IVC obstruction is there, then that right side varicocele will occur. So that if suppose there is a patient has right side varicocele also, or patient has bilateral varicocele, then we have to do screening with ultrasound to rule out any IVC thrombus. This thrombus can be tumor thrombus, it can be bland thrombus also. So what is the bland thrombus? Bland thrombus is the patient with the DVT, deep venous thrombus, the patient on prolonged bedridden, patient just some tumor thrombi reach to the IVC. And the other thing is the persistent cough, usually seen in the patient is a metastatic condition. So that most common metastatic site is the lung. Okay, so that because of lung involvement due to metastasis, the patient will present with the persistent cough. Other is the bone pain. Bone pain because of osteolytic metastasis. This one also question, like RCC metastatic or blastic or lytic. So lytic, these are osteolytic metastatic, blastic prostate, CA prostate metastatic or blastic. Other you can thyroid malignancy also osteolytic, pulsatile, RCC also pulsatile. Pulsatile osteolytic tumor is the other is the cervical lymphadenopathy because lymphatic metastasis, and other is last one is the paraneoplastic syndrome. So you will get one question in from this slide also. So paraneoplastic symptom usually seen in this symptom related to tumor, or in case of metastatic, sometimes tumor secretes some hormone or some peptide that cause symptoms. So most common paraneoplastic syndrome is the raised ESR. So this one is the question. So most common paraneoplastic syndrome is the elevated ESR. Other is the hypertension. Why hypertension in the renal tumor? Because large tumor compress the segmental vessels. Because of segmental vessel ischemia, that lead to the activation of RAS, renin-angiotensin system. Because of renin-angiotensin activation, so there is a salt and water retention lead to the hypertension. Why anemia in the renal tumor? Because of hematuria. Sometimes patient has gross hematuria. In such patient, usually came with the serum hemoglobin 5, 6, 7, and hypercalcemia due to parathormone related gene peptide. So this keep remember another MCQ on this. The hypercalcemia treatment is the usually hypercalcemia treatment because of malignancy is the treatment is surgical, but in this the treatment is the steroid or bisphosphonate. So treatment is the medical treatment. So hypercalcemia related to renal malignancy treatment is medical, diuretic and bisphosphonate and steroid. Second last is the polycythemia. Why polycythemia in the renal tumor? Because patient has anemia also, you can think that polycythemia, RBC count high, no? And patient has anemia also. So polycythemia because erythropoietin secreted by renal kidney. So because of the elevated erythropoietin level, there is the RBC count will be high. So everything is logic, not you have to not remember that like mugging type. Everything you just think. And another is Stauffer syndrome. So what is the Stauffer syndrome? Is the non-metastatic liver dysfunction. Suppose patient has renal tumor secreting some interleukin that damage the liver. So this is the non-metastatic, and there is no metastasis to liver, but there is a patient has raised SGPT, SGOT, elevated serum bilirubin. So this is the non-metastatic liver dysfunction. So this is known as Stauffer syndrome. So what is the Stauffer syndrome? Non-metastatic dysfunction. So treatment of Stauffer syndrome is radical nephrectomy. After removal of the kidney, all the liver enzyme will be settled down. So this one also question, that the treatment of Stauffer syndrome is radical nephrectomy. What is the Stauffer syndrome? Is the non-metastatic liver dysfunction. So this most common site of metastasis is lung. And lung, what you will see? Cannonball secondaries. So this one also cannonball secondary seen in the lung metastasis. In bone, metastatic bone is the osteolytic metastasis. So osteolytic metastasis, then patient can develop pathological fracture. So how to diagnose the renal tumor? These are basic investigation. We have to look for that pre-op workup also. Patient will go usually for surgery, so that CBC, and for pre-op workup, and we have to rule out if tumor size is large, then we have to rule out that paraneoplastic this symptom also. So for the, we have to do ESR to look for paraneoplastic syndrome, serum calcium, so and serum creatinine as a part of, we have to look see other kidney function also. If raise serum creatinine, then better to counsel the patient also. Urine analysis to look for microscopic or macroscopic hematuria. Serum LDH, alkaline phosphatase. Alkaline phosphatase for bone metastasis. If alkaline phosphate is elevated, then most likely there is a chance of bone metastasis. So usually we are doing ultrasound as a screening. When ultrasound confirmation screening, then need to confirm with CT scan. CT scan is triphasic CT scan. Which CT scan is the triphasic? Triphasic arterial, venous, and delayed image. So plain is the not part of triphasic CT. Keep in remember this thing. So arterial, venous, and delayed image. So on CT scan, what you will see, there is a contrast enhancement of more than 15 Housefield units. So in your question also, if he wrote that after CT contrast enhancement, tumor enhancement is more than 15 Housefield units, directly go for malignancy. And the CT scan, other thing, CT will give information about the function of opposite kidney, tumor extension, and there is a venous involvement, and status of regional lymph node, and status of adrenal gland, and other metastatic site, liver and spleen, other organ metastasis. So this is the coronal image of CT scan, that showing that there is a large renal mass with renal vein thrombus reaching to the IVC. There is a dark color shadow, large marker showing that this is a renal vein thrombus reaching to the IVC. The thrombus is hypoenhancing. So then role of MRI. So MRI usually not done. MRI usually diagnosis confirmed by the CT scan. So one thing I can tell you, one thing usually come in mind, that any tumor we have to go for biopsy. So why for renal tumor no need to go biopsy? This CT is the confirmatory thing. So no need to. What is the drawback of the biopsy? Biopsy, there is a tumor seeding to the tract. So there is a disadvantage of biopsy. So directly CT is giving 99 more than or around 100% sensitivity and specificity. So directly go for radical nephrectomy or partial nephrectomy. So no need to take biopsy. So what is the role of MRI? MRI especially role in case of the renal vein involvement by thrombus. So to look the level of thrombus, the thrombus level in the renal vein below diaphragm or above diaphragm or in the right atrium. So to look for level of thrombus, then investigation of choice is the MRI. So look at the thrombus level of thrombus is question asking the level of thrombus. Then we have to, then investigation of choice the MRI. Or if there is no specific for any abdominal mass, investigation of choice is the contrast enhanced CT scan. Other role is the angiography. Angiography, especially we are planning for partial nephrectomy to look for any blood vessel, if any blood vessel, feeding vessel going to the tumor or not. So we can directly selective clamp that only that the branch of the artery that going to the tumor. Venacavography, MRI is the investigation of choice. If MRI not available, then venacavography to look for obstruction of the IVC. So thrombus level, we can also identify the venacavography, but this is the invasive approach. Other is the non-invasive approach is the MRI. What is the role of FNAC, FNA biopsy. I already told you that no need to take biopsy. This is the confirmatory. Then why is role of FNAC? So FNAC role in the patient with going for active surveillance or patient going for the tumor ablative procedure. Suppose the 80-year-old male person is unfit for surgery and we are planning for active surveillance. Then in such scenario we have to confirm the diagnosis. So this is actually this is a tumor or not. Because patient is unfit for surgery, we are planning for keep on follow-up. So in such scenario, we have to take the biopsy and to confirm that this is the RCC, then we can follow up on regular ultrasound. Chest X-ray as a part of pre-op workup and to look for metastasis. These are cannonball metastasis. And bone scan when patient is elevated alkaline phosphatase and patient has bone pain and patient with the hypercalcemia. So now is the tumor staging. So most common classification is the TNM classification. Previously, another staging procedure is that Robson staging. So this is MCQ Robson staging done for RCC. So but nowadays every malignancy is new classification, TNM classification we are using. So this classification is depend on the size of the tumor, lymph node status. So up to T2, you can this staging also come in your question. So basic idea I can give you up to T2, the tumor is confined to the kidney, and T4 is the outside the Zerota fascia, and T3 is the in between, in pelvic-calyceal system, perinephric fat, renal vein, and IVC. All this is the basic idea is up to T2, tumor is confined to the kidney. The difference is the T1 is the up to 7 centimeter, T2 is the more than 7, less than 10 centimeter. This is the Robson staging. Robson in diagram showing the tumor within the capsule, and stage 2 is the tumor invasion to perinephric fat, but inside the Zerota fascia. The outside lining is the Zerota fascia. And stage 3 is the tumor involvement of the regional lymph node and renal vein or vena cava. Stage 3. Stage 4 is the involvement of adjacent organ. This is a RCC involving the colon. So Robson staging for the renal cell carcinoma. So this is the prognosis. Stage 1 survival, 5-year survival is the 95% after partial or radical nephrectomy. For stage 2, 5-year survival is the 88%. So up to stage 2 means up to tumor limited to the kidney. So up to if tumor is limited to kidney, prognosis is very good. Up to 88% 5-year survival. For stage 3, 5-year survival is the 60%. For stage 4, 5-year survival only 20% of the case. So what are the prognostic factors? Prognostic factor is the ISUP grade. These are 4 type grade 1, grade 2, grade 3, grade 4. So if higher grade, there is high chance of the recurrence of the tumor or progression of the tumor. A tumor size is the small tumor, good prognosis. Large tumor is the bad prognosis. Venous invasion is not a good sign. Venous involvement is the T3 stage 3rd. So this in stage 3rd there is a from 88 to 60% survival. So 28% survival reduction is there. So this is the venous involvement is the bad sign. Renal capsular invasion. If capsular invasion tumor going to the T3 stage. So the T3 advanced stage, the prognosis is poor. Adrenal involvement, prognosis poor. Histological type, clear cell RCC, worse prognosis. And chromophobe RCC is the good prognosis. Lymph node enlargement also bad prognosis. And presence of paraneoplastic syndrome is the bad prognostic sign. So what is the management of the tumor? So tumor has the first you can understand what is the radical nephrectomy, what is the simple nephrectomy, what is the partial nephrectomy. So radical nephrectomy, I can show one diagram. Keep in mind this thing. In radical nephrectomy, this is the Zerota fascia. This is the Zerota fascia. So all thing outside this whole thing removal is the radical nephrectomy. If removal only kidney part, this one part, This is a simple nephrectomy that is for non-malignant disease. Suppose non-functioning kidney, pyelonephrotic kidney. In that case, we are doing simple nephrectomy within the aorta fascia. This is a simple nephrectomy or radical nephrectomy. All things removed inside the aorta fascia. Because why involvement in aorta fascia? Because it will decide tumor staging. A tumor going to the beyond aorta fascia T4. So this is the radical nephrectomy. Everything inside the aorta fascia we have to remove. That is a radical nephrectomy. Other is the partial nephrectomy. Other minimal invasive method are thermal ablative therapy, cryosurgery, high intense focal ultrasound. These are for a small tumor, a small multifocal tumor, and patient with the already CKD, high creatinine level. In such patient, these are minimal invasive method. Other treatment are immunotherapy, targeted therapy, and radiotherapy for advanced or metastatic disease. So indication of nephron sparing surgery. Nephron sparing surgery, partial nephrectomy. So indication is bilateral synchronous tumor. So we can't remove both kidney. So we have to go for partial. Other a tumor in solitary kidney, can't remove whole kidney. So solitary tumor in the solitary kidney, bilateral tumor, and significant renal failure. Patient already a creatinine 3. If you will remove one kidney, then creatinine will go 5, and then later on patient will go for dialysis. So in such patient we have to we can preserve as much as renal parenchyma. So absolute indication are these three. Relative indication, contralateral kidney has pre-existing renal disease. Suppose the patient has multiple PCNL on left side and right side renal tumor. So that or left side that there is a huge obstruction, thin parenchyma. Then we have to think that this kidney already compromised and better to preserve renal parenchyma or renal function. Or the tumor of 4 to 7 centimeter in presence of normal contralateral kidney. Contraindication of partial nephrectomy, very large tumor, 9 centimeter tumor. So 9 centimeter, if you will remove 9 centimeter, how much of the parenchyma will remain? So for partial nephrectomy, at least 33% of parenchyma should be remain. Otherwise, there is a hyperfiltration injury occur, and then kidney will go severe albuminuria and hyperproteinemia. Patient develop proteinemia and need to remove that part also. So there is a large tumor, and where is the negative tumor free margin could not be achieved. And other is the patient with a large tumor with renal vein thrombus or IVC thrombus. So in this we have to remove the tumor and thrombus also. So there is no role to partial nephrectomy in such case. So if renal vein IVC thrombus in such patient there is no role of the partial nephrectomy. Even T3 tumor also, T3 T4 tumor, renal vein T3 is already renal vein or IVC. In TNM staging I told you T3A is the renal vein, T3B IVC below diaphragm, this thing. So radical nephrectomy is the gold standard treatment of localized disease. However, the recent increase in the incidentally detection of the small renal mass less than 4 centimeter, in such case partial nephrectomy should be treatment of choice. Both surgery we can do in laparoscopic approach, robotic approach, and open approach also. Because of the limitation of ischemia time, minimally invasive techniques should be reserved for the tumor with non-complex anatomy, as predicted by nephrometry score. So there is a nephrometry renal score is there. In that score there is a criteria up to 6 score, 6 to 9 or more than 9. The total score is a 12. If higher the score, there is a chance of the complication are high. So better go for open surgery. If there is score is low, then we can go for minimal invasive approach, laparoscopic or robotic approach. Alternative technique is the active surveillance in the patient with unfit for surgery in elderly male more than 80 years, because in elderly male the tumor is the slow growing tumor, and slow growing tumor there is a chance of invasion and metastasis are less. Radical nephrectomy. So what are the components? I already discussed the component. Classically, radical nephrectomy involves removal of the entire kidney enclosed in the aorta fascia with ipsilateral adrenal gland and regional lymph node. So that all kidney, ipsilateral adrenal gland, and regional lymph node. So this is the radical nephrectomy total. So this is the classical term for radical nephrectomy, but we are not doing every case adrenal. We can't remove adrenal in every case. So we are seeing in CT scan, if the adrenal on imaging the adrenal is normal, then we can spare the adrenal gland. Other are the indication is the upper pole tumor. So adrenal also in upper pole, there is chance of invasion is high. So in upper pole tumor, we have to remove the adrenal gland. If lower pole tumor, no need to remove adrenal gland. Surgical management of IVC thrombus. Renal tumor associated with IVC tumor thrombus in 5 to 10% case. This, remember this percentage. So if thrombus extending into the retrohepatic and suprahepatic segment of IVC require full mobilization of liver and giving incision on IVC and removal of or thrombus. But if suppose the thrombus extending up to the right atrium need cardiopulmonary bypass. So management of metastatic RCC. This whole thing I discussed. This is the localized RCC. Now the metastatic RCC. So before treatment management of metastatic RCC, most common site of metastasis, second row, lung. Most common route. So for IMDC score, this one is the IMDC score also written in Love and Bailey. Also keep remember IMDC score used for the metastatic, not a localized RCC. Keep in mind, if both option is there localized or metastatic, then answer will go for metastatic RCC. So these are 5 components of RCC. On the basis of these, each carry 1 mark. So depend on this. If there is a score is 0, then good prognosis. Then survival is the 43 months. If metastatic RCC patient IMDC score is 0, then chance of survival is the around 3.5 years. If suppose intermediate score is 1 to 2, then survival is 22 months only. And third is the poor. The score is the 3 to 6. Then patient survival is 8 months. So if patient already score is poor, score is high, and come in the poor risk group, then no need to give any, better to palliative care. Because survival only is 7 to 8 months. So 1/3 of patient presented with the advanced disease at time of presentation. Primary treatment is systemic therapy. Systemic therapy means for RCC we are not giving chemotherapy. So keep in mind in RCC other term using a targeted therapy. Targeted tyrosine kinase inhibitor, or other is the immunotherapy, that immune checkpoint inhibitor. So keep in mind chemotherapy is not used, the term chemotherapy not used for RCC tumor. Any renal tumor either targeted therapy or immunotherapy. So TKI, tyrosine kinase inhibitor, is the inhibit the vascular endothelial growth factor receptor. The drug name is sunitinib or pazopanib. So these drugs improve the survival in patient with metastatic RCC. So the first is the targeted therapy, other is the RCC is the immunogenic tumor. So it will respond with the immunotherapy. So first generation immunotherapy agent are interleukin or interferon. But nowadays recently developed that immune checkpoint inhibitor. These are anti-program death ligand, inhibit the PDL1 or PD1. Though this is the mechanism of action of checkpoint inhibitor. So this is the T cell and this is the antigen presenting cell with the tumor antigen. So suppose the tumor cell, the T cell having CTLA receptor, then APC antigen presenting cell binds the CTLA4, then lead to the inactivation of the T cell. So if we will give this drug inhibit to this receptor, then that inhibition will not occur and then T cell activation will start. So this drugs are ipilimumab or ipilimumab block the CTLA4 receptor. Similarly, this is the tumor cell having PDL1 and the T cell having PD1. If suppose both are binding, lead to inactivation of the T cell kill the tumor. So if we can give either block this PDL1 in PD1 receptor or either PD1 receptor. So if both receptors is among them one receptor block, then tumor the T cell inactivation will not occur, or lead to the tumor T cell activation and then respond of the T cell to tumor cell. Other is the cytoreductive surgery. So I told you radical nephrectomy, partial nephrectomy, simple nephrectomy. This other term is a cytoreductive nephrectomy. So cytoreductive, the all radical are for localized tumor. This is the metastatic tumor. So metastatic tumor we can't tell the radical nephrectomy term. So for that is the cytoreductive. Cytoreductive why? Because one thing, these are 3 points. One is the as a part of palliative purpose. Suppose patient has severe hematuria. With a renal metastatic severe hematuria, then we have to remove the kidney. So this removal of the kidney is the cytoreductive. Patient has intractable pain. Patient has severe pain because of retroperitoneal nerve involvement. So in such patient, because of to relieve pain, we have to remove that kidney. The purpose is not that for that cancer control. Purpose is the different. So symptomatic. So palliative purpose. Okay. So this is the palliative. This is known as cytoreductive. Other thing is the other new recent study they are showing that because of the maximum tumor burden in the kidney, and this tumor because of tumor burden, if we can remove this kidney, then later we can give that immunotherapy. The immunotherapy response will be higher. So these are 3 indications of cytoreductive nephrectomy. Other in children is the Wilms tumor. This is the most common tumor in childhood, accounting 5% of all childhood cancer, and they are bilateral in 5% case and familial in 1% case. Wilms tumor gene is the tumor suppressor gene, and derived from the embryonic nephrogenic tissue, namely as blastemal. These are undifferentiated, and the blastemal component is poor prognosis. Other are epithelial tubule and stroma. Typical percentages in the children with age of 4 to 5 years of either gender with large palpable abdominal mass that may cross the midline, and child has hematuria, hypertension, fever, weight loss, and because of this in this tumor the pain is relatively uncommon. Large tumor can rupture and present with the acute abdominal, intraperitoneal, retroperitoneal bleed. Management for as a CT scan as a part of staging workup, and treatment is the radical nephrectomy with pre or post op chemotherapy, and both regimes that pre op chemo or post op chemo has comparable survival of 90%.